Introduction. Good afternoon, medical students, and welcome to today's lecture on gastroesophageal reflux disease, GERD. Today, we will delve into the intricate pathophysiology of GERD, discuss the various diagnostic methods, explore treatment options, and touch upon associated complications. With the aim of providing a comprehensive understanding of this common condition, we will also examine specific subsets of patients, such as children, the elderly, and those with respiratory or upper gastrointestinal disorders. So, without further ado, let us begin our journey into the captivating world of GERD. Gastroesophageal reflux disease, GERD, is primarily caused by a malfunctioning lower esophageal sphincter, LES, allowing stomach acid to flow back into the esophagus. Impaired esophageal clearance and various contributing factors such as hiatal hernias, obesity, and certain medications can worsen GERD. Clinical presentation of GERD includes heartburn, regurgitation, dysphagia, chronic cough, hoarseness, chest pain, and asthma exacerbations. Endoscopy is used to identify complications, including esophagitis, Barrett's esophagus, and strictures. Empirical therapy with acid-suppressive agents can aid in diagnosis and treatment. When diagnosing GERD, diagnostic tests such as esophageal pH monitoring, manometry, endoscopy, and barium swallow studies can provide valuable information about acid reflux episodes, esophageal motility, lay function, and structural abnormalities. Each test has its strengths and limitations, and the choice depends on the patient's presentation. Lifestyle modifications play a crucial role in the management of GERD. Educating patients about dietary adjustments can have a significant impact on symptom reduction. Recommending a low-acid diet, avoiding trigger foods, for example, spicy or fatty meals, carbonated drinks, caffeine, and opting for smaller, more frequent meals can alleviate symptoms. Weight loss is encouraged in overweight or obese individuals, as excess adipose tissue can increase intra-abdominal pressure and worsen GERD symptoms. Elevating the head of the bed by 6 to 8 inches can also prevent acid reflux during nighttime, as gravity helps keep gastric contents in the stomach. This elevation can be achieved by using bed risers or placing wooden blocks beneath the bedposts. Implementing these lifestyle modifications can significantly improve GERD symptoms and reduce the need for medication. When treating GERD, two common medications are proton pump inhibitors, PPIs, and histamine 2 receptor antagonists, H2-RAS. PPIs, like omeprazole, stop acid secretion by blocking the H+/K+ ATPase pump. H2-RAS, such as ranitidine, reduce acid secretion by inhibiting histamine receptors. Medication choice depends on various factors. In severe or refractory GERD, surgical intervention like fundoplication or LINX device placement may be necessary. These procedures strengthen the lower esophageal sphincter, LES, to prevent reflux. Factors like symptom severity and response to medication should be considered before deciding on surgery. Untreated or inadequately managed GERD can lead to various complications. Esophagitis, characterized by inflammation and erosion of the esophageal mucosa, is a common complication. The severity of esophagitis is classified using the Los Angeles classification system, ranging from grades A to D. Barrett's esophagus refers to metaplastic changes in the esophageal mucosa, primarily due to chronic acid exposure. The presence of Barrett's esophagus increases the risk of developing esophageal adenocarcinoma, a potentially lethal malignancy. Strictures, resulting from the healing of severe mucosal damage, can cause esophageal narrowing and dysphagia. GERD can also manifest beyond the esophagus, leading to extraesophageal complications. Chronic cough, asthma exacerbations, laryngitis, and pulmonary fibrosis have all been associated with GERD. Recognizing and managing these extraesophageal manifestations can improve patient outcomes. The relationship between GERD and Barrett's esophagus signifies an increased risk of developing esophageal adenocarcinoma. Barrett's esophagus, characterized by the replacement of squamous epithelium with specialized intestinal metaplasia, is considered a premalignant condition. Surveillance strategies, such as periodic endoscopies with biopsy sampling, aim to detect dysplastic changes early. Dysplasia within Barrett's esophagus ranges from low-grade to high-grade. High-grade dysplasia warrants intervention due to an increased risk of esophageal adenocarcinoma. Management considerations for Barrett's esophagus involve a multidisciplinary approach, including gastroenterologists, pathologists, and surgeons. These individuals collaborate to establish an individualized plan, considering the extent and severity of Barrett's esophagus, patient preference, and overall health status. GERD can cause or worsen respiratory conditions like asthma, chronic cough, laryngitis, and pulmonary fibrosis. Treating GERD can improve asthma control, alleviate chronic cough, relieve laryngeal symptoms, and potentially prevent pulmonary fibrosis in some cases. Pediatric GERD has unique clinical presentations, such as regurgitation and feeding difficulties in infants, and heartburn or chronic cough in older children. Diagnosis involves clinical evaluation and potentially diagnostic tests. Treatment includes lifestyle changes, diet modifications, and careful use of medications. A multidisciplinary approach is crucial for effective management. In elderly patients, GERD can present with atypical symptoms that mimic other age-related conditions. Management of GERD in the elderly should consider comorbidities, polypharmacy, and medication interactions, while also addressing the unique challenges faced in this population. GERD often coexists with other upper gastrointestinal disorders like O, PUD, and functional dyspepsia. Differentiating between these conditions is crucial due to distinct management approaches. Managing GERD in conjunction with these disorders requires careful evaluation and personalized treatment plans. In conclusion, our exploration of GERD has provided insight into its causes, diagnosis, treatment options, complications, and considerations for different patient groups. Recognizing its diverse presentations and employing evidence-based strategies is crucial for improving patient outcomes and reducing long-term consequences. Thank you for your attention, and I hope this lecture has prepared you for managing GERD in your medical practice.